ladies and gentlemen, esteemed colleagues and distinguished guests, good morning and heartiest welcome to the inaugural session of Head and Neck COMPLICON. Dr. Pradhan's contribution to surgical oncology are immeasurable, and his pioneering work in conservative laryngeal surgeries has not only shaped the practice but also has inspired generations of surgeons around the world. On a personal note, sir, my first encounter with Dr. Pradhan sir was during my time as a young surgical resident at Grant Medical College and JJ Hospital, Mumbai. So every Wednesday at 9 p.m, sir used to hold a class for all surgical residents, and we were all eager to attend sir's case discussion. Despite of his incredibly busy schedule, sir took time to teach us the management of head and neck cases. So we used to take turns and present cases. So we had a WhatsApp group who would discuss what. So his greatness was not just only imparting the knowledge and kindness, he also used to provide refreshments during those late sessions. As a first year PG, I relied on those refreshments as my nourishment. So reliving those days, I now fully realize the extent of Pradhan sir's dedication and commitment. So the WhatsApp group which we had created is fondly called as PARK group. So that is Prince Ali Khan group. It has more than 120 members and it is still active now. So we keep discussing what we were doing before. And Pradhan sir, even in his young age, he is deeply involved in academics. Sometimes we and our residents still attend his Monday morning 8 a.m. class. So it's a privilege to attend it. Thank you so much. Just as Rahul Dravid is known as the wall of cricket, where he is able to stop the ball from hitting the wicket, Dr. Pradhan is the great wall of head and neck oncology. His teachings prevent us from hitting complications. Sir, thank you for guiding us through safe aspects of surgery. So Dr. Pradhan truly epitomizes what it means to be a surgeon. His calm demeanor, methodical approach, and profound compassion makes him not just a great surgeon, but a great human being as well. Sir, we are deeply honored to have you today to deliver our first ever Head and Neck COMPLICON Oration. Ladies and gentlemen, please join me in welcoming the legendary Dr. Sultan Pradhan. I would request our source of inspiration and energy, Dr. VSS sir, the legendary and senior most surgical oncologist, I can say the world actually, and head of our institute, to introduce Dr. Pradhan sir to everyone. Sir, it's better. Oration.
Please.
I am extremely proud to welcome Professor Sultan Pradhan to deliver first oration on the head and neck surgery, complications in head and neck surgery. I think all of you in the hall know about him, and I don't think I need to speak more. Let us first start with the oration. And sir, we are really honored, greatly honored for your presence here and also for delivering the oration on the head and neck complications in surgery.
Ladies and gentlemen, thank you Dr. Srinath, Dr. Karthik and all the organizers for inviting me. I don't get invited these days. They give you a lifetime achievement award and all that it announces is that's it.
So it just means more to come, sir.
But I'm happy to be here. Happy to be standing here before you. Feel privileged, and I'm really very happy to to see the kind of topic that you have chosen, the theme that you have chosen, complications in head and neck surgery. The transformative advancements that the field has made in this head and neck surgery really need to be highlighted. What we are doing is not just focusing on better and better cure rates. I think the surgeon is focusing on how he can reduce the complications and the burden of complications. Without that, the quality of life is very much affected. 52 years ago, I joined the Tata Memorial Hospital at the age of 27. I want to do some mathematics. The landscape of head and neck surgery in those days was very, very different. Very, very different. Subspecialties in surgical oncology had not yet taken root. We were all general surgeons doing all general surgical oncology. We operated on everything that came our way, from mandibulectomies to mastectomies. We did axillary node dissections and groin node dissections and cervical lymph node dissections and retroperitoneal lymph node dissections. We did it all. And we thought we were doing very well, confident in our skills, but really we were not focusing on anything. In those days, the recovery room concept had not yet set in. Patients after major surgery used to go down directly to the ward. And often, life-threatening complications like airway obstructions resulted in very dire complications. And that was really the order of the day in those days. It was a surgeon's hospital. Every patient that came to the hospital was registered under a surgeon. He operated on the patient. He made the treatment decision. He operated on the patient if he thought surgery was the best. What he felt he couldn't operate, he sent them off to radiation therapist. Radiotherapist has no real say in the matter. The concept of joint clinics, tumor board, evidence-based treatment decisions had not yet started. Radiation therapy was also in its infancy in those days. We had two radiologists who would report on the X-rays and then go and do radiation therapy. Chemotherapy was nowhere into consideration. In those days, the only solid tumor that was treated with chemotherapy was choriocarcinoma of the uterus. Ultrasound, CT scan, MRI was not available. Very often treatment decisions on oral cancer, maxillary tumors were made based on whether the patient has trismus or he doesn't have trismus. And time and again you had to have the embarrassment of finding out midway through surgery that the disease is unresectable, that the retromaxillary tissue is packed with tumor or the pterygoid fossa is packed with tumor. We've come a long way since then. Now the surgical specialties, the subspecialties have developed, and if I have to give credit for one single transformative advancement, I would say that it is the visionary directors of the cancer centers who introduced subspecialties. This is how all the various subspecialties of surgical oncology developed. And that is where the real advances came about in every subspecialty, and head and neck has not been left behind. As we honed our skills into surgical oncology, today I can see the resident doctors and fellows, the way they do a composite resection or a laryngectomy or a thyroidectomy or a parodontectomy. I don't think we were doing it as well, even when we were assistant surgeons and on the faculty. At a time when we were doing everything. I think that this focusing onto a specialty has really developed the field very, very well. And as you hone your skills into this surgery, you come to know that you can do something more. That radical surgery does not have to be just whacking things off, just ablative surgery. That there is a lot of conservation of form and function that can be done in radical cancer surgery without compromising on the safety. The conservation surgical procedures came up. Take, for example, just a radical neck dissection. It is an integral part of almost every squamous cancer in the head and neck. And by doing that surgery repeatedly, they now have modifications of the radical neck dissection, and one of those, the accessory nerve is preserved. And otherwise, we used to routinely sacrifice the accessory nerve. The patients used to get a very ugly drooping shoulder, stiffness, a lifetime of aches and pains in that. Today, in majority of the cases, the accessory nerve will be preserved. If two conservation procedures that I can talk about were really if you look at the complications of head and neck surgery, I would like to group them into three. First is the postoperative complications of airway obstruction, reactionary or secondary hemorrhage, wound breakdowns, wound infections, carotid blowouts that we used to have in those days. A lot of these we have overcome a lot of these because of better recovery rooms, better nursing, resident doctor training, and awareness. These have really now not been the very major concerns. The two other groups of complications that I look at are one, where following major ablative surgery, you have really damaged the form and function. And the third, the mother of all complications, is a recurrence of cancer. And it is in these two areas where the head and neck surgeon has contributed a lot to reduce the complications. The burden of complications has been reduced a lot by the head and neck surgeon focusing onto the outcomes that were there with major ablative surgery, where he now started the conservation trends. And in two areas that one can see, one is where the mandible is sacrificed, and the other where the larynx is sacrificed. They're the most devastating complications. The moment the patient comes and you tell him your jaw will be removed, and he thinks of the disfigurement, the malalignment, the inability to chew and swallow, or you tell him that your larynx will be removed and he'll be rendered speechless and he'll have a tracheostomy for lifetime. Look at how these two have been addressed by the head and neck surgeon At one time at the Tata Memorial, hemimandibulectomy and total laryngectomy were the leaders on the list of daily operation schedule. And what were we doing hemimandibulectomies for? One, of course, when the mandible was involved or there was extensive soft tissue invasion around the mandible, you're justified in resecting that mandible. But we used to resect the mandible only to get wide of the tumor in the floor of the mouth because we couldn't get adequate margins, or the tumor was in the buccal mucosa near the deep sulcus and we couldn't get adequate margin, and we resected a segment of the mandible and gave the patient gross deformity of the face, malalignment, inability to chew, swallow, speech affected. And the other reason why the mandible used to be resected was to get access to a difficult oral tumor or oropharyngeal tumor. Today, in both these situations, the mandible is no longer sacrificed. In order to get a wider margin, you do a rim resection, a marginal mandibulectomy, and avoid the disfigurement. Or to gain access, you do a mandibulotomy, resect the tumor, and replace the bone, and once again avoid the deformity. It has really been a transformative advance. We analyzed more than 300 cases of consecutive hemimandibulectomies at the Tata Memorial. In the early 80s, I did this analysis. And in more than 50% of cases, the mandible was unaffected. Even the X-ray findings, in those days CT scans were not there. Even the simple X-ray had predicted that the bone was not involved. So all these, what we were doing, mandible, all these oral cancers where we were sacrificing the mandible, today we don't do that. And that is a paradigm shift. If you see the way the surgeon has evolved the treatment of cancer of the larynx, it's once again stage by stage by stage improvement in the quality of life, maintaining the as best a cure rate as you can get, but giving a better quality of life. So when high energy radiation therapy machines came in, and the radiotherapy started treating early cancers of the larynx and got good cure rates in stage 1 and 2 cancers, it was an awakening call for the surgeon. And he started developing partial laryngectomies, the conventional partial laryngectomies, vertical partial for the glottic cancers, the horizontal partial for supraglottic cancers. And these were really the excitements in the 70s and the early 80s, or all through the 80s. And they gave comparable cure rates to what radiotherapy could give, but preserved speech. But they required hospitalization. They required a temporary tracheostomy. They needed a feeding tube. So he went a step further, and from the 90s onwards, he developed transoral laser microsurgery, which has really been a paradigm shift. Today, very, very infrequently do we do open partial laryngectomies. And I keep telling Dr. Pai, the 3 books that I've written are really outdated because of this transoral laser microsurgery that has come in. That is the kind of transformative advancements that head and neck surgeon has brought about in the field of laryngeal cancer. For T3 cancers, the gold standard used to be a total laryngectomy. In the 70s and the 80s, this used to be the gold standard. At the Tata Memorial, as a policy, we used to not do a total laryngectomy up front for most patients, even in advanced cancer, because we felt let us try with radiation therapy. A few will succeed and save their voice. In those that do not succeed, we will salvage them with a total laryngectomy. Institutes that followed this policy claimed that this policy is justified if and only if you can salvage 2/3 of the known failures. So we analyzed our results, because really the institute in which the entire country placed its confidence, and people from all across the country came to the Tata Memorial to have that treatment. In those days, these centers were not there. They placed their total trust into the center, where we were doing a procedure which was not the gold standard. Total laryngectomy was the gold standard. We were offering them radiation therapy. And what was the result? Our salvage rate was just 8 to 10%. It was a disaster. It was a disaster. And a lot of them, after salvage surgery, used to have carotid blowouts. Many of them. But anyway, they were all dying. And that one study changed the policy of the Tata Memorial. And we said, no, we cannot treat these T3 cancers with radiation therapy. We have to do surgery. But surgery was a total laryngectomy. So the surgeon again asked, can I do something better? And that is where, in the 80s and the early 90s, this procedure of a supracricoid partial laryngectomy, the extended open partial laryngectomy procedures came in, which offered the patient very high local control rate and preserved his speech and swallowing and avoided a tracheostomy. That is the way the entire science of laryngeal cancer has evolved, where the surgeon has played a very, very important role in transforming to see that not only does the patient get a good cure rate of local control rate, but his speech and swallowing are preserved. There are many other areas that the surgeon has contributed this way, and where conservation is not possible. Reconstructive surgeries came up, and the mandible is now being replaced. A T prosthesis is put in where laryngectomies and the speech is restored. So really, if you see in head and neck surgery, how the evolution has occurred is so impressive, so truly impressive, where the surgeon's mind is continuously on how we can improve the quality of life without compromising on the cure rates. As far as recurrences are concerned, in the late 70s itself, the surgeon realized, I can't do it all on my own. And that is the time when the concept of combined modality treatment came up. At the Tata Memorial, if we did a composite resection and the pathologist reported all margins clear, and we told the radiotherapist that it was an advanced cancer, treat him with radiotherapy, they said, no, have the courage of conviction. Margins are clear, this patient will not need radiotherapy. But science showed that no, if this was a stage 3 or a stage 4 cancer, even if you have done a satisfactory resection and the pathologist has reported that the margins are clear, that patient needs radiation therapy. You do that and you reduce your rates of recurrence. Same way later in the 90s, chemotherapy finally made an entry into head and neck oncology. And once again, what chemotherapy did was, further reduce the complication rates in these advanced cancers by nearly 4 to 8%. And also, what chemotherapy did was, if you combine it with radiation therapy, you got a very good organ preservation plan where surgery could be totally avoided and high complication rates avoided. This is how science has evolved. The science of head and neck has evolved, and it is a process of continuous evolution. William Osler very wisely said once, the practice of science is the practice of science is an art, not a trade. It is a calling, not a business. It is a calling where the heart is exercised with the head. Every time you think of something, the heart is in it. How can I do it better? What will be the quality of life for this man? Not just how I will cure it. What we are doing is not just resecting or saving lives. We are preserving dignity. And we are constantly, as you've seen in laryngeal cancer, constantly pushing the boundaries of what is possible. And the path ahead is going to be the same. We have to continuously evolve. If the paradigm shifts that we have seen today, they are only the beginning. Surgeon will continue to push the boundaries and see that we get better and better results, not just disease control wise, but with the quality of life. And this is an unending thing. A very senior surgeon and former director of the Tata Memorial used to very often make a statement. In his closing statements in orations, and he gave many orations, he says, surgery, ladies and gentlemen, has plateaued. Advances in oncology will now have to come from other disciplines. Molecular biology, for one. I did not agree with him. Much as I admired him then, I did not agree on this. And time has shown that we have continued to evolve, and I believe that we will continue to evolve together. Thank you.
No, sir, that just shows how much you know the field in and out. I think head and neck surgery runs in every RBC within you. Sir, thank you very much for delivering the inaugural head and neck Complicon oration. As you mentioned, Osler's quote, surgery is an art, go by your heart. Sir, you are the heart of this Complicon. Sir, thank you very much again. I request Dr. B.S. Srinath, sir, to felicitate Dr. Pradhan, sir.
Please. No, sir, please. It's absolutely, sir.
I request everyone to raise and give Dr. Pradhan a standing ovation. Dr. Radhika and Srinath.